breech presentation or evidence of antenatal fetal compromise. If a woman presents unexpectedly with a breech presentation in established labour, then the decision as to the mode of delivery should depend upon the stage and progress of the labour, whether or not any adverse factors can be identified during the labour, and there should be appropriate expertise present, and the woman should give informed consent.
There are various options for birthing positions when giving birth to a baby presenting by the breech. The mother may be either upright on all fours or in a semi-recumbent position, her legs supported in stirrups and the bottom of the bed removed to allow for access during delivery. If the top of the bed cannot be moved to prop the mother up, an assistant may kneel behind her and support her. There are several different types of breech presentation. The safest position for vaginal breech delivery is with both legs extended. However, one or both legs may be flexed and at the level of the fetal buttocks, and it is acceptable to deliver either an extended or flexed breech vaginally. If the presentation is footling, with one or both feet presenting considerably below the breech, then there is an increased risk of cord prolapse, and it is advisable to perform a caesarean section. Wait until the breech is well descended and preferably visible before encouraging active pushing. Once the breech descends the perineum, evaluate for episiotomy. This is not always necessary, especially in multiparous women and those with a perineum that stretches well. If the perineum is tight or more rigid, a right mediolateral episiotomy should be performed. Once the buttocks have delivered, it is best if the entire delivery is completed within 5 minutes, as further delay has been associated with an increased risk of adverse outcomes. However, if the delivery is progressing, then there is no need to interfere, and it is best to allow the birth to continue spontaneously without holding the baby. Previous protocols advised pulling down a loop of the umbilical cord once delivery had progressed to the level of the umbilicus, but this is no longer recommended. When holding the baby to undertake any manipulations, it is important to hold the baby by the bony pelvis with your thumbs either side of the sacrum and your forefingers on the iliac crests in order to avoid causing trauma to the abdominal organs. Some operators prefer to hold the baby using a towel to avoid slippage. The baby's legs may deliver spontaneously, but in the case of extended breech, splinting of the legs against the abdomen may delay delivery. To avoid this delay, once the back of the knees become visible below the perineum, flex and abduct the legs by applying pressure to the back of the knees one by one. Do not try to deliver the legs by putting your fingers between the legs and the baby's body, as legs cannot bend backwards. Once the legs are delivered, allow the body to deliver spontaneously with maternal effort until the scapulae become visible. If the baby's back is tending to rotate, gently turn it by holding the pelvis so that the back is uppermost. Once the scapulae are visible, in many cases the arms will deliver spontaneously, but if not and the arms are flexed, assist the delivery by reaching the antecubital fossa and drawing the arm down across the fetal chest. In difficult cases, especially when the arms have become impacted above the baby's neck, you will need to undertake Lovesets procedure. This is a rotational procedure when descent of the shoulders beneath the symphysis pubis is aided by turning the baby, holding the baby by the pelvis. Once the baby is held by the pelvis, rotate the body through 90 degrees so that the fetal back is lateral. Run a finger up over the anterior shoulder from behind to the elbow, flex the arm at the elbow and draw down across the baby's face and chest to deliver. Again, holding the baby by the pelvis, rotate through 180 degrees so that the other shoulder is anterior, and repeat the process with the second arm. If you are unable to reach the arm with the initial rotation, then you can repeat the process. Once both arms are delivered, gently rotate again through 90 degrees so that the back is again uppermost, and allow the baby to hang to aid descent and flexion of the fetal head. It is often necessary to aid the delivery of the fetal head using the Morrisseau-Smellie-Veit procedure. To do this, once the nape of the baby's neck is visible, Rest the baby's abdomen on your forearm and hand and place the first 2 fingers of this hand on the baby's cheekbones. Do not put any fingers in the baby's mouth to avoid damage. Place the first and third fingers of your other hand over the baby's shoulders and your middle finger over the occiput to aid flexion of the head. Ask the woman to push and guide the head through the outlet following the pelvic curve, but avoiding overextension of the fetal neck. In difficult cases, descent and flexion of the head can be aided by an assistant providing suprapubic pressure to supplement maternal pushing efforts. In rare cases, it may be necessary to deliver the fetal head using obstetric forceps. Ask an assistant to hold the baby in the horizontal position, taking care not to hyperflex the baby's neck. The forceps blades are applied from below, using the fingers of your free hand to guide the forceps blade into place while protecting the maternal tissues. Once both blades have been inserted, lock the blades together and apply traction to steer the fetal head through the curve of the pelvis. If forceps are used, it is frequently necessary to perform an episiotomy. As neonatal resuscitation may be needed following breech delivery, if possible, aim to have an assistant standing by to commence resuscitation whilst you manage the 3rd stage of labour following delivery.